Good evening. My name is Nasser Taha. I'm a professor of cardiology in Minya University. We are going to talk about new frontiers in the hypertension management. Actually, we have a lot of new frontiers in hypertension. One of the most important and is most rapidly progressive field is the M-health, or the mobile health, and the E-health, which is electronic health. This includes improvements in the screening of hypertension, hypertension management, and hypertension diagnosis. And also the technology have been implemented in very special groups like atrial fibrillation. Future research is also needed in this field, which is rapidly progressive. Drugs in the pipeline and the pipelines are going to be addressed, and also the device-based neuromodulations. The M-health introduction into the screening of hypertension is extremely needed, as 30 to 50% of the hypertensive patients remain undiagnosed worldwide. And also 25% of the patients who are diagnosed as hypertensives are actually not hypertensive and only have white coat hypertension. Self-screening is a very important and have been introduced in many guidelines by the home blood pressure measurement and out-of-the-office blood pressure self-screening stations, like in the pharmacies, and the grocery stores, and in the self-monitoring equipments in the physician waiting rooms, in the physician waiting room, not in the physician clinic. So these maneuvers have also some limitations because of the limited privacy and the poor availability of the facilities. Newer technology, including the smartphone applications, have introduced new frontiers in the screening for hypertension. Apple Watch have been introduced with a cardiogram application, and this predicts hypertension from inputs from the heart rate and the step counts. It predicts hypertension and does not measure the blood pressure. The sensitivity for prediction of hypertension is 85%, and the specificity is a little bit lower, which is about 64%. This program, the cardiogram, has also predicted sleep apnea by a sensitivity of 90% and a specificity of nearly 60%. However, this failed to predict diabetes. This program, the cardiogram, is now available and can also utilize other wearable devices than the Apple Watch, which are Android devices, Garmin device, and Fitbit device. This is the Apple Watch, and as you see, it can measure the heart rate and measure the amount of activity that you are doing. Limitations of this technology in screening is that it needs a further research to verify its diagnostic utility. The current market penetration of the smartphones in the elderly group that is most susceptible for hypertension is still not sufficient. Also, the cognitive dysfunctions, the visual and hearing impairments of these elderly patients might impair the use of smartphones and renders this technology usage at this age group difficult. The most important diagnostic tool that we have for diagnosis of hypertension is ambulatory blood pressure monitoring. Many guidelines have recommended this, and these guidelines have recommended the use of ambulatory blood pressure before the diagnosis of any case of hypertension as in the United Kingdom. This will eliminate about 25% of the patients that have white coat hypertension from being treated falsely as hypertensives. The device measures the blood pressure every 15 to 30 minutes but during the day, and 15 to 60 minutes during the night. The most important limitation is the cost and the time limitations. Not all the patients can afford wearing it for 24 hours, and also it is uncomfortable and disrupts their daily life and also disrupts sleep. Cuff-less blood pressure monitoring devices have been implemented, and there are two main cuff-less devices using the smartphones. One of them is on the Android platform and is free to download, but it has not been validated. The other one uses, it's called the instant blood pressure, and it can measure the blood pressure in 10 seconds. However, its technology has not been disclosed, and it costs $5 to download this application, and it can be used over the smartphones. One iOS application that is can be downloaded on the Apple is the instant blood pressure. It reveals a poor accuracy of blood pressure measurement. However, its mean difference between the actual blood pressure and the blood pressure measured by this device mounts up to 12.4 millimeter mercury for the systolic and 10.1 millimeter mercury for the diastolic. And this renders 1 in 5 patients to be misplaced or misdiagnosed as hypertensive. The My Blood Pressure Lab that is working on the Android uses a different technology. It measures the plethysmographic wave in the fingers or the wrist, and measure the transit time, the pulse transit time from the ECG to the pulse wave reaching the wrist. And this, out of this transit time, it will measure the blood pressure. This transit time is related to the blood pressure, but is also dependent on the arterial compliance, arterial wall thickness, arterial radius, and the blood pressure density, and the blood density, sorry. For that, this device should be calibrated before usage in a certain person by a cuff-based blood pressure monitor. So, before using this device, you should calibrate it to yourself, and then you can measure the blood pressure using this device later on. Wearable devices, including the watches and B Pro, these are wearable devices that can send signals to your smartphone, and hence it can measure your blood pressure. The heart tone watches, the watches usually, they measure the blood pressure through the pulse transit time, as we have said, and this costs about $150. On the other way around, B Pro is a tonometrically device, tonometry using device, and it can measure the systolic and diastolic blood pressure, the heart rate, and the pulse waveform. And this wearable device costs about $2,000. But this device is approved by the ESC, European Hypertension Society, for the using in the non-ambulatory settings. 21% of the United States adults own smartphones, and this gives a good opportunity to track or they own either the smartwatches or fitness trackers, and this gives them a good opportunity to use these devices to measure the blood pressure. The tricorders are the third group of smart devices that can monitor the blood pressure. The tricorder is first used in, or first invented in the Star Trek movie, and in this movie the device can get all the physiological signals from the body and diagnose most of the diseases. However, we are not now capable of doing this. What we are capable to do is measuring some physiological signals like the heart rate, the SpO2, the EKG or the ECG, and systolic and diastolic blood pressure. One of the first devices is FreeScan, and this device should be applied on the radial artery and put some pressure on the radial artery to measure the blood pressure. It measures the pulse transit time, and it costs about $225. Biometrics also is another device that uses pulse transit time. It uses a similar technology. It should be put on the hands, not using pressures to get the signals, but it uses infrared, and it costs around $300. SmonTouch is another device. It's an accurate device, but it gets the signal, the pulse transit time, from plethysmographic signal from the tip of the hand, of the finger. And this is fed into the device, and the device can measure systolic, diastolic blood pressure, the heart rate, the SpO2, the ECG, and the sleep patterns. It is a very sophisticated device, and that's why it has been approved by the ESH and validated for non-ambulatory also settings, and it costs $5,200. Dollars. Drawbacks: the accuracy and precision has not been confirmed. Inaccurate measurement may be false patient reassurance, may lead to false patient reassurance, unnecessary healthcare utilization, and misdiagnosed, misjudged the self-titration of hypertension medications. The patient may increase or decrease his medications unnecessarily. Misdiagnosis of hypertension could also lead to psychological stresses and unneeded exposure to adverse side effects of medications. An error of 5 millimeter mercury, just 5 millimeter mercury, will lead to 21 million normotensives and 27 million hypertensive patients being misclassified. Pulse transit time is sensitive to motion artifacts. That's why it is usually cannot be accurate. It is not accurate in the setting of exercise and so. Furthermore, the software and the data transfer to the other device, to the mobile phone or to other stations, may be critically underdeveloped nowadays. And it is presently unclear how the measured values in real life will be related to clinical or cuff blood pressure home cuff-based home blood pressure measurement. So we don't know if the data that we are gathering from the electronic devices can be equivalent or even different from the cuff-based devices that we have now. So we need prospective clinical trials to verify this. Worldwide, the control rate of hypertension only ranges between 8% and 70%. In the United Kingdom, with a very efficient National Health Service, yet only 60% of the patients with hypertension are controlled. Newer technology can improve the control rate by self-monitoring, telemonitoring to virtual clinics, and by artificial intelligence assisted managements. Self-monitoring is an important thing. Home blood pressure monitoring have been advocated years ago. However, it is better to use the self-monitoring to better predict end organ damage and improve blood pressure control. Tracking the average blood pressure over time by the electronic devices is easier. These electronic devices can also give an alerting concern of blood pressure event trends, and can give us an information about blood pressure variability patterns like dipper or non-dipper. Furthermore, what aids the control is self-titration of medications. But this needs a very reliable device to allow the patient to change his medication depending on his blood pressure measurement. Application of telemedicine, the transfer of data, is called telemonitoring. But the most important that we should send these data to a certain station that can utilize it and can give the patient feedback. Automatic data transmission from blood pressure readings devices to the smartphones is already, through the Bluetooth, is already available. Also, it is the combined transfer of other data, other physiological data like the heart rate and the oxygen saturation, pacemaker, defibrillator data is already present, either through the internet or through transtelephonic connections. It is, in a study in the United Kingdom, they found that the telemonitoring of patients is cost-effective and costs less than 20,000 sterlings per quality-assisted life year. Virtual clinics or visits is a very novel approach for treatment of patients with hypertension. Asynchronous online interactions between the patient and the clinician to extend the medical care beyond the initial office visit. So the first visit should be done in the clinic, and later on follow-up visits can be done on a virtual basis. A study by Levin et al. 2 years ago have showed that the virtual visits versus real life in-person visits has no significant difference regarding the systolic blood pressure control, the number of specialist visits, the emergency department presentations, or the inpatient admissions. All our smartphones use artificial intelligence algorithms. And if you have an Android, so you have an Alexa, and if you have an Apple phone or iPhone, you will have a Siri in these phones. They can update medication lists and can set reminders to make the medications, to take the medications and improve adherence to treatment. Incorporation of large telemonitor database allows data mining and for comorbid conditions to be discovered. Blood pressure data can be combined with blood glucose and heart rate and exercise that allows adaptation of management recommendations. There are two famous databases, one of hypertension and diabetes, WellDoc, and Omada Health for digital programs. Special groups, one of the most important limitations of the cuff-less blood pressure measurement is atrial fibrillation. Hypertension can cause atrial fibrillation, and if atrial fibrillation occurs in hypertensive patients, these patients are more likely to get strokes. Automated blood pressure devices are not validated for measuring patients, the blood pressure in patients with atrial fibrillation. These devices, which are accurate in the sinus rhythm, cannot be assumed to maintain their accuracy for measurement in atrial fibrillation. So all guidelines recommend that atrial fibrillation patients should have their blood pressure measured manually with a cuff by a healthcare provider. Further research, a lot is needed. New technology to be assessed in the clinically validated settings. How best the clinicians and the patients can integrate these advances into daily practice. Much previous research have excluded patients with additional or complex needs, such as very elderly, multimorbid patients, and pregnant women. These are excluded from all clinical studies. And furthermore, white coat hypertension may be very different prognosis, may have a very different prognosis in pregnancy as compared to the general populations. Now we are going to shift to another very important topic, which are the drugs and the pipeline. One of the most important is the aldosterone synthase inhibitors. The aldosterone synthase inhibitor, one of the most important of them is LCI 699, also called Ozeldo-Rostat. It is an 11 beta hydroxylase inhibitor. In a study with a blood pressure, baseline blood pressure 151 over 9 to 1, it could reduce the blood pressure significantly over 8 days and over 25 days compared to placebo, both systolic, diastolic blood pressure, without affecting the potassium level. Endothelin antagonists have been thought that they can reduce the arterial blood pressure. Bosentan is one of the most important of these. However, it works very nicely in pulmonary arterial hypertension. The Golutril is a combination of endothelin converting enzyme and neprilysin inhibitors, and they both have a borderline efficacy in arterial hypertension, but may be more beneficial in pulmonary arterial hypertension. Guanylate cyclase activators, that includes Riociguat and phosphodiesterase inhibitor 1 inhibitors. Both of them have been thought that they can affect the blood pressure and reduce it. However, they can only work for chronic thromboembolic pulmonary hypertension and arterial pulmonary hypertension. And as you know, that phosphodiesterase 5 is also used as in patients with erectile dysfunction. Collagen cross-link breakers have been thought that they can affect the prognosis in patients with diabetes, especially and has been called the anti-aging drugs. However, the experimental studies showed a very usefulness of these drugs. However, clinical studies have shown no benefits in humans. Now, the most important topic is the anti-angiotensin 2 vaccine. Thinking about vaccine that we can take once or twice yearly, or maybe every 2 years, that cures your hypertension is a fantastic idea. But I will show you how difficult to get a vaccine. And as you know now, in the coronavirus epidemic that we have, you see how difficult to develop a vaccine for this virus. The goal of the vaccines against cancer or the viruses is the activation of the cytotoxic T cells in addition to antibody formation. Vaccines are being developed as a therapy against diseases such as Alzheimer's disease and hypertension. In hypertension, we are targeting the angiotensin 2. In the Alzheimer, we are targeting the amyloid material. Vaccines for Alzheimer have caused aseptic meningoencephalitis due to activation of the innate immunity, and that's why it has been stopped. Therefore, the short antigen peptides carried on a carrier are used for hypertension vaccines to stimulate beta cell activation and avoid activation of the innate cytotoxic reaction. And as you see here on the left-hand side, the beta cells are activated by the pathogens like bacteria or viruses, and also these viruses activate the dendritic cells that are the antigen-presenting cells, and these will present the antigen using a major histocompatibility peptide to the T cells CD28 B7 receptors. And activation of the T cells will cause these T cells to change into cytotoxic T cell, and these will kill the antigen, the cells that carry the antigens. On the other way around, they also activate the B cells, and the B cell activation will cause the antibody formation to neutralize the pathogens. For hypertension, we use a very short sequence, less than 8 peptides. This short sequence should be carried on a carrier that is recognized by the body as self. And so the antigen, which is angiotensin, will activate the beta cells, the B cells, and the plasmablast cells, and this stimulates the antibody production. And antibodies will neutralize or stop the angiotensin 2 from working. On the other way around, the angiotensin 2 and the carrier, KLH, will, in the presence of adjuvant, will activate the dendritic cells, leading them to stimulate the helper cells that will activate once more the B cells to produce antibodies, but they will not cause the activation of the cytotoxic T cells. and so no cytotoxicity would occur. This needs a very specific carrier to be adjoined to the angiotensin molecule to initiate only the humoral immunity and do not initiate the cytotoxic immunity. For cancer and infectious diseases, we need the toxic T cell activation. For the lifestyle-related diseases like the hypertension or Alzheimer, we need only the introduction of antibody production. The goal in the first is the T cell activation, while the goal in the second is the antibody production by the beta cells. The antigen in the first includes the major histocompatibility complex of class 1 and 2, but the antigen in the second, in the hypertension vaccine, should exclude major histocompatibility class 1 and 2 by using very short peptide sequence. The carrier is not needed in the cytotoxic T cell activation, but is important in the antibody production. And adjuvant also is different in each of the two molecules, pathways, sorry. And now we can, these are all the studies that has been done during the last 20 years on vaccines for hypertension. And as you see, in 2003, angiotensin 1 analog with KLH have been introduced, and the vaccine have been given to 50 healthy men. It increased the antibodies titer, however, did not affect the blood pressure, and there was no safety concerns. Another trial in 2004, the same results, and but here was a double-blind trial. In 2006, angiotensin 2 with alum has been given to 12 patients and 4 placebo patients. It increased the antibody against angiotensin 2 and no change in the blood pressure and no safety concerns. In 2008, another angiotensin 2 vaccine have been tried in 24 patients at low dose, 24 patients at a high dose, and 24 patients on placebo. And here it increased the antibodies, and also the high dose could reduce the blood pressure significantly. But the high dose group only that worked in this. And also there was no safety problems. In 2010, angiotensin therapeutic vaccine with a novel adjuvant has been introduced, and the randomized double-blind trial have showed a lot of dose-limiting adverse effects, and that's why this trial stopped. And in 2018, another vaccine, DNA vaccine, have been introduced and tried on 24 patients in a high dose 9 and 9 in low dose, and 6 patients on placebo, and the trial has not did not report its results yet. SGLT2 inhibitors is very important drugs for the treatment of diabetics, but also it can treat hypertension in diabetic patients. And as you see here, the algorithm for using this, the algorithm of mechanism of action of these drugs. This is the normal physiology, and the pathophysiology in patients with systemic diseases like diabetes, chronic kidney disease, congestive heart failure, and the metabolic syndrome. And this is how it works in if we put the SGLT2 inhibitors. Clinical trial, the SARCA trial, have shown in a subgroup with ambulatory blood pressure monitoring that the systolic blood pressure have been reduced during the nighttime blood pressure, the daytime, and the 24-hour blood pressure significantly as compared to placebo. I remind you once more, this is an anti-diabetic drug that significantly reduced the blood pressure in ambulatory blood pressure monitoring. The diastolic blood pressure followed the same pattern. During nighttime, daytime, and 24 hours, all reduced significantly. Not only this, but also the clinic systolic blood pressure and diastolic blood pressure were both reduced by the drugs, the empagliflozin, and also home blood pressure monitoring was significantly reduced compared to the placebo, both systolic and the diastolic blood pressure. My final topic is the device-based neuromodulation. The baroreceptors activation is carried out with one of these devices, and this is a device which is called the CVRX. It has two electrodes that is placed around the carotid arteries bilaterally, and it only causes its stimulation. On the right-hand side device, it is a single lead device which is called Barostim, and this is the newer device. It is smaller in size and it has only one lead that is attached only to the one side of the carotid. The device delivers activation energy through the carotid artery, the carotid leads. This will stimulate the carotid baroreceptors, and this baroreceptors will send signals to the brain that the brain will interpret as elevated blood pressure. And thus the brain will send signals to the blood vessels, the heart, the kidney to reduce the blood pressure. The REUS pivotal trial have showed that if we immediately, if we put the device, it will reduce the blood pressure over 6 months. And in this trial, half of the patients have activated their device immediately, and the other half have activated their device 6 months later. And in both conditions, we see that the blood pressure have responded very, very nicely to its 25 millimeter mercury reduction by just the stimulation of the carotid arteries. Efficacy, marvelous, but the problem is that 9% developed transient or permanent nerve damage, and 5% had general surgical complications. For that, the FDA did not approve the use of this device. For that, the Barostim Neo is the unilateral stimulator that might be safer, but the trial in the United States have been stopped as the company did not have enough money to sponsor this trial. The other way of device reduction of blood pressure is the renal denervation. And Simplicity 1 and Simplicity 2 has shown that the concept is valid and the blood pressure really is reduced. However, Simplicity 3, which is the first trial in hypertension that uses a sham design, have showed that both the renal denervation and the sham devices and the sham procedure reduce the blood pressure to the same extent. So the renal denervation have failed to reach a good goal in Simplicity 3. For that, this stimulated the DINNER hypertension trial, which is an ambulatory daytime average systolic blood pressure trial, and this showed that renal denervation significantly reduced the blood pressure versus the standard therapy. But this was not a sham-controlled trial. But one of the most important things, that the number of medications the patients used was actually reduced at 6 months. And this is an important issue in the management of patients with hypertension. Now, the last trial is the spiral hypertension of medications and spiral hypertension on medication trial and radiance trial. And as you see, either if the medication's on or the medication's off, the medication was off for 3 months, and after the 3 months, the medications have been given. And as you see, the renal denervation was better than the standard control. The radiance trial is also showing the same effect. However, these trials were not sham controlled. So, the remaining questions of renal denervation are which patient is most likely to benefit of it, the extent of ablation that is needed to reduce the blood pressure effectively, the type of energy most effective to be reduced, the usefulness in patients who are medication responsive. If the patient is responsive to the medications, it is useful. Is it useful to have renal denervation of these patients, and how long would the effect last? And do these nerves regrow once more or not? Ladies and gentlemen, I do thank you very much for this, for listening to me, and have a good time.